Your presentation.
Can you hear me?
Yeah, you can continue with the presentation.
Sorry for the inconvenience due to the technical issue. Now we see the image of the week presentations. A 20-year-old male is a chronic alcoholic and a smoker presented with a thigh with the complaints of headache for the past 7 days. This headache he developed after a 3 days binge of alcohol consumption, which is throbbing in drive, predominantly left-sided, and this has been aggravated on moving head positions. This headache is often associated with vomiting and blurring of vision. The negative issues are there is no diplopia, seizures, loss of consciousness, altered sensorium, and difficulty in eye movement. The examination findings, we didn't have any specific findings in the examinations. So let us see the images. Any final PGs can comment on the images, please.
Yes, any of the final year PGs? Govind is there? Govind?
Yes, ma'am, I'm here.
Yes, please comment on the CT.
The images are, I can't actually make out the details on that, ma'am. The images are
Dr.
not very
Amir,
clear.
I think you need to focus on the individual pictures. Dr. Amir,
Yes,
please
ma'am.
put up the pictures again. The pictures are now there on the screen. That's
Ma'am,
better.
also, yeah, one second, ma'am. Ma'am, although the pictures are not clear on zooming, I think that there could be a venous sinus thrombosis, ma'am, of the posterior as well as the right-sided transverse sinus, ma'am.
All right, Govind. Continue, Amir.
As we know, there is hyperattenuation, which is noted on the right transverse sinus and even a superior sagittal sinus. Most of the time, the hyperattenuation in the sagittal sinus can be a normal variant. So next we have to do the venography. And this is a normal venous anatomy. And the hypertension sign is the earliest sign, which can be seen in the initial part of the presentation. When another earlier presentation is gyral swelling, which can be noticed by effacement of the adjacent sulci. In the CT venogram, there will be a delta sign, as there will be filling defect will be noted. See, and this is hyperattenuation, which is noted on the transverse sinuses, and that's a dense triangle sign or dense clot sign, which is seen in the sagittal sinuses. And another sign is a cord sign. This is cord sign means there is a hyperattenuation is noted on the transverse sinuses. This can also known as cord sign, which is other name variant of a delta sign. And it is a CT venography where there's a filling defect noted on the sagittal sinuses. These two images, and one of the DD for the sagittal sinus, empty delta sinus, arachnoid granulation, which is a normal variant, which can be looking like a empty delta sinus. Actually, there is a filling defect noted on the sagittal sinus area. And while coming out to MRI, in MRI there is two type of images, T1 and T2 weighted images. The basic difference in T1 and T2 is the water will be white. That's World War II. Therefore, CSF will be white in color in T2 weighted images. And in the in the first images, it's a acute CVT, which is noted as hyperdense in the T188 images, and in T2, there will be hypodense in the T2 images. And this is a basic difference why there is an hyperattenuation, isoattenuation in the T1 and T2 weighted images. And in the early part of CVT, we will get a vasogenic edema. Due to the venous obstruction, there will be increased pressure. So, in some article, there have been proposed theory that we can use steroids for this vasogenic edema to treat the patients. But there is no proven benefit. We can give steroids for the vasogenic edema. Once there is a raised pressure, and that will be leading on to cytotoxic edema. And the basic difference between vasogenic edema and cytotoxic edema I was given in the PPT. There is a blood-brain BB disruption will be there, and there will be white matter will be normal in vasogenic anemia, and the gray matter differentiation will be preserved in vasogenic edema. Most commonly seen in tumor abscess. As you all know, cytotoxic edema is more common in ischemia. There will be white matter differentiation will not be there. And thank you for having the lecture. And this is a case of CVT.
Hello.
Hello, yes,
Can you-
doctor. What is this presenting complaints? Dr. Amir, what was the presenting complaint for this patient?
Headache, ma'am. Headache for the past 7 days.
Okay, no vomiting, projectile vomiting.
No,
was
vomiting
also
is there.
there.
Headache for the past 7 days, so associated with vomiting for the past 3 days, which was projectile and not bile stained, not blood stained.
Okay. Does any of the faculty would like to elaborate on the imaging, please?
I didn't get you, ma'am.
No, I'm asking if any of the faculty would like to elaborate on the image, please. Would like to add on. Dr. Rohini? Dr. Rohini?
Can you hear me?
Oh, yes, and now I can hear
Yes,
you.
I think, yeah. So I think whatever that he showed on the slides are quite explanatory.
Yes,
So
self-explanatory.
I
yes.
think, yes. So I think it was a very nice presentation by all the 3 presenters today. Dr. Tenmodi, Amirthalingeshwar, and Ideraj. In spite of a few technical glitches, I think it has gone off well as a initial presentation the first time after a long break.
Thank you, Dr. Rohini, and your team
Madam,
members.
1 minute.
Yes, sir, please, sir.
Yeah, I think as Madam has said, like they are presenting it after a long period of time, and most of the things they have forgotten. Like so, the conventional way which we have the physician conference in Stanley. But anyhow, like it's present. Who is the presenter for this case? Like.
Dr. Amirthalingeshwar.
Yeah, Amit.
Yes, sir.
What is how did you manage this case?
Basically, we are given anticoagulant, sir, like heparin for the first 2 days, and we bridged with acetrom, sir.
Yeah, okay. What is the etiology for this CVT? What is the age of this patient?
28, sir.
28. Why in 28 years, like the patient had CVT?
Alcoholic intake and vomiting leading to dehydration. Most probably leading to CVT. Hypercoagulable state is also there.
Yeah. So that is the thing. Like usually, like we talk about all these things. Like when the patient got admitted, like recently or long back?
Recently, sir, some 7 days back.
7 days back. In that scenario, like one thing which I would like to say, like even today we had a long discussion. Exactly remember a similar kind of case by name Muttu, 32 years, on the right side of the ward in M1. Similarly, the patient had an alcoholic binge. By 7 o'clock, 7:45, the patient had thrown a seizure, and he was brought in a little bit altered sensorium, and he had some headache kind of thing, and the patient was diagnosed provisionally, made a diagnosis of CVT. So the thing is, what I'm trying to say is like, so there are certain things like the headache can give us some kind of idea with regard, because when you talk about the CVT, like the cortical vein can go for obstruction. Your sagittal sinus, superior sagittal sinus, cavernous sinus, lateral sinus, transverse sinus. There are so many sinuses or venous channels are there. Like they do have some kind of, they are anatomically, I don't want to go into that, the anatomical differences with the other venous channels elsewhere in the body. And each channel has got its own kind of the clinical presentation as well. So say, for example, if you take a headache itself, like so the headache is quite common, like so headache is quite common in patients with the cortical vein thrombosis, and with patients with superior sagittal being the bigger venous channel, like so that could result in a headache as a predominant symptom. So suppose if somebody is having a lateral sinus kind of thing involvement, they may have something like similar to that kind of pain just over or beneath or around that ear area, and they may mimic like a mastoiditis kind of thing also. So the thing is like, it's I'm just giving you some kind of clinical manifestations by which we can find out the possible without any imaging. Once we have the clinical diagnosis provisionally, once we suspect, so without any imaging, we can locate the thing also. Similarly, a patient with ophthalmoplegia, of course, the diagnosis would be very simple, cavernous sinus. Seizures are quite common only in patients with cortical vein involvement, commonly in patients with cortical vein involvement, and patients with superior sagittal and transverse, like it is quite common. Whereas with the lateral sinus, it's not so common, and sigmoid sinus also, like we don't get seizures. So like that, like so depends on the thing. Like so, I would have been more happy if some third year or second year PG, so volunteer, so how they could approach this case based on the symptomatology. So that is more important. So because again and again, I'm telling you, like the symptoms, the bedside thing, what we get from our patients, that is more important, and that can give you a clinical clue to the, of course, if when you take a CT scan, you can get a clot sign or a delta, empty delta sign or something like that. So we go on to do AMR, AMRV, or MRI. So all these kind of the DSA, all these things are entirely different. Again, with regard to the etiology, like there are certain things are common. Yeah, alcoholic, they can have not that like a bout of alcohol, a bout of vomiting would result in a dehydration kind of thing. So it's I do not know like how the concept has come. Of course, the alcoholic binge drinking, and if they drink for day and night for together for 2 or 3 days, like they are maybe at risk of developing some kind of dehydration, I would say. With one alcohol intake and one episode of vomiting, I don't think they'll go for a dehydration kind of thing. But considering again the prevailing situations, what is existing now, the possibility of the venous thrombosis, particularly in patients, certain high-risk populations, particularly in patients with alcohol, the COVID-19. So the COVID-19 is a condition where we do see a lot of cases, not today, not yesterday. For the past 4 or 5 months since the second wave is declining, like so we have been seeing a lot of cases of venous thrombosis, because the second wave is more thrombo-inflammatory than the first wave. So we do see since May month, like we see a lot of cases of mesenteric ischemia, patients presenting to us with CVT, patient presenting to us with the DVT, all these kind of things. Again, it's quite, I don't think the patient would be RT-PCR positive, but it's worth doing an antibody test for RT-PCR to find out whether the patient has at least had exposure kind of thing. So that is a thing. I think there are some common things like hyperhomocystinemia, and where it commonly it causes arterial thrombosis. But remember that hyperhomocystinemia can result in even venous thrombosis also. Then protein C, protein S, antithrombin 3. So these are all some of the rare things. But local infections, yeah, these patients are at risk of developing some poor hygiene or something like that, some mastitis or ear infection, a mild infection that could result in vasculitis and extension into the venous channel. Again, that is a possibility. So these are all some of the things like which we need to get, but rather like we know that like so it's a very basic undergraduate discussion that like how do you differentiate the arterial stroke from a venous stroke. So there are different things are there, but the thing is like the patient with venous stroke, like there are certain risk factors. Yeah, dehydration, of course, post-operative cardiac failure, prothrombotic state. So there are certain risk factors, I do agree. But I don't think this one bout of vomiting could result in CVT kind of thing. I think it's worth doing some kind of some evaluation. Like, see, we should not stop with just to convince that like a patient had dehydration. And did they ever, the people who first examined the patient, so did they ever dry skin, mucous membrane dry, and skin fold? Did they check blood pressure? Did they check tongue moist? And so these things are whether it was demonstrated. So I just wanted to ask, like it was not so demonstrated in most of the things, but still the patient was given a diagnosis of dehydration and possibly CVT kind of thing. So in this case, worth considering this patient for at least not RT-PCR, but the COVID antibodies. So that is worth considering in this case with regard to, because it's a futuristic, because we do not know, like even 1 year later, they are at risk of some, because after the end of first wave, the people are coming to us with some different problems. Like they do develop so many non-communicable disease kind of thing with patients who already had COVID in the first wave. So like that, like maybe second wave, the virulence and the severity, the exponentially, the magnitude of the second wave, which we have seen was it's devastating, and it was maybe they may come to us in the future years with some arterial or venous thrombosis also. So this is also, we do see a lot of patients with the COVID patients after a month or two, they do land up with myocardial infarction, stroke, and so many complications they do come with arterial and venous thrombosis. There are Behçet is one condition, APLA is one condition, COVID is one condition where they can hyperhomocystinemia is a condition, like where they can have both arterial and venous stroke. So we need to remember such kind of thing. But more important is the analysis of the symptoms. You said the patient had seizure, you said patient had a headache, and so this is a triad. A patient with papilledema, headache, and seizure. It's a triad wherein we can suspect a CVT. So those things should strike you. Okay. So I think Amirthalingam, like I would be more happy if you throw more light on the clinical aspect. Of course, you've done the imaging part of it, so you are rightly shown that. But how do you take this, the clinico-radiological correlation? So if you do that, I think it would be more apt for the beginners, the first years. Okay.
Okay, sir.
Good afternoon, sir.
Thank you.
Good afternoon, sir. This is Dr. Amirthalingeshwar. Sir, actually, Amirthalingeshwaran missed history, sir. This patient was abstinent from alcohol for 1 year, sir, followed which had a continuous binge of alcohol for 3 to 4 days, followed which he developed recurrent vomiting, sir. Vomiting for 3 days. That is followed by headache.
Oh, then see, the
So
thing
he
is
gave
like
the
that's
typical
what.
history.
Oh, okay. In that case, like I agree, but not with
So,
one episode of vomiting.
No, sir, he had continuous recurrent vomiting for 3 days, followed which he developed a headache for 7 days. After 7 days, he presented with full-blown raised ICT, like headache, seizures, and on examination, he had papilledema too, sir.
Yeah, so that's what, like,
So,
I think you've thrown the right part, which I am trying to emphasize.
Yes,
See, again, the clinical thing, the information which you are giving is a beautiful information, where it would be like the PGs should look for these kind of thing, the clinical correlation. So that is more important. So as you rightly said, I extend my appreciation to Dr. Uma. So thanks, Dr. Uma.
thank you.
Rohini? Dr. Rohini, please. Dr. Rohini? Am I
மேடம்
audible?
இல்லைன்னு மேடம் இல்லைன்னு நினைக்கிறேன். இருக்காங்களா?
I think she's very much there, sir.
Hello, can you hear me? Can you hear me, sir?
Yes, I can hear you,
Good
Dr.
morning,
Yes,
madam.
yes, yes, yes. So should we wind up now, sir? I think it has
Yes,
been a
madam.
nice
Yes, madam.
discussion
Yeah.
overall. And next time, I think around we'll be having offline, which would be possibly a better way to go about next week
Yes,
onwards. Mhm.
yes, and that. But anyway, despite that, online it was a good presentation, I must say.
Yes, just the technical glitches off and on, it is there. Other than that, it was wonderful. Thank you very much.
Dr. Rohini. Thank you, Dr. Idiraj, Dr. Teenmuri, and Dr. Amir. Sir, shall we wind up, sir? Thank you,
Yes,
sir.
madam. Yes, madam. Yes, madam.
Thank you, sir. Thank you. We wind up together. Thank you.